Hello, everyone. My name is Kaveh Seydan, as you can see on the screen. And the name of this presentation is Optimizing Implant Aesthetics, Traditional and Digital Techniques. It's an honor and a privilege to have this presentation for International Congress of Oral Implantologists, ICOI. And I caught a bad cold about 2 weeks ago. Still, I'm suffering from the voice condition, so I try to speak a little bit more slowly. At least my words are more understandable. Anyhow, this is my Instagram page. I would love if you can get connected to each other and we can share what we know about dentistry and prosthodontics. I'm working in prosthodontic field since 35 years ago, and now I'm retired from the school. I'm just doing my private practice. I'm not going to show you very complicated cases that usually residents of prosthodontics will do them. I'm going to show you very simple cases that we face in our daily practices in our offices. So let's start with aesthetics. About 35 years ago, when I started with implant prosthodontics, the issue was not aesthetics. The issue was osseointegration itself, because in those times, when a surgeon placed implants and the implants were successfully osseointegrated, everybody was happy. But these days, if the final result of any kind of treatment in the industry, from fixed restoration on natural teeth to implant restorations, does not look aesthetic and does not satisfy the aesthetic demands of the patient, it would not be considered as a success. So the primary factor in defining success these days is aesthetic itself. And there are so many different factors governing the aesthetic of an implant restorations, from implant placement to implant abutment configuration to abutment material itself to prosthesis design and insertion protocol. And all these factors has so many sub-factors that if I want to discuss all of them in details, it will take at least a day, a full 8 hours of training. So I just have 1 hour and I will just skip from all these factors and sub factors, and I will just point to very, very important factors and sub factors in determining the aesthetic in anterior implant restorations. The first case is a very, very simple case. This young lady was referred to me about 8 or 10 years ago, 8, 9, 10. I cannot remember exactly what was the timing, but when she was referred to me, she was 31 years old, and she had a car accident, and she had major maxillofacial surgery operations, 8 different maxillofacial operations in the mid phase, and the final operation was to place 2 implants in the upper left central and lateral incisors. And as you can see, the restorative dentist has placed 2 single cemented crowns on top of those implants. It's an FP3 prosthesis with some gum porcelain in the cervical area. And it looks good. It looks good, at least here, not acceptable, but the patient was not happy with the result. And when she came into my office, she was a severe gummy smile. You can see more than 5 millimeter of gingiva is showing when she was smiling. And she told me that she was not able to smile since she has restored these implants. And she cannot convince or find any surgeon, any maxfax or any periodontist to explant these 2 implants and place some bone graft, tissue graft, and place 2 new implants for her. So she walked into my office and seeked a kind of prosthodontic solution for this problem. Of course, FP3 processes is a very good and old solution for class 3 seabird defects, and this is a class 3 seabird defect. I took out the crowns, artificial crowns. You can see that both the width and the height of the bone has been damaged by the car accident. Two cemented crowns, I took them out. Two angled abutment. Again, I unscrewed them and take them out, and there's a little bit of inflammation around the implants. And I asked my dental technician again to make another FP3 prosthesis, but this time a screw-retained prosthesis, and this is the porcelain try-in phase. And although the case is not finished, the aesthetic results looks much more better than the cemented crowns over there, and the lab work was much more better. So this is the final result for the patient. You can see with the help of a very good, knowledgeable dental technician, you are able to solve the problem of this patient, at least to face the problem of this patient, because doing some kind of vertical bone augmentation and also some soft tissue graft for these patients is very difficult, and the results in most cases are unpredictable. So FP3 prosthesis is very helpful for these kind of defects. In conclusion of the first slide, I have to tell you that the most important factor governing the aesthetic of anterior implants is the position, is the location of the implant. Both in these photographs, the left side and the right side, you can see that in the left side, the implant is placed too far buccally, and in the right photograph, you can see that the implants are placed too far palatally. And there could be no prosthetic solution for these implants. The only solution for these cases to explant them. So FP3 prosthesis is not a solution for all cases if the location of the implants is poor. Another case, you can see that two tissue level implants were inserted for this young actress, very young, beautiful actress. And the first mistake is to use the tissue level implant in the aesthetic zone. And the second mistake is that the location of the implants is too far buccally. There is no bone at the buccal surface of the implants. You can see when the flap is raised, there is no bone at the buccal surface. Both implants were explanted. Bone graft were placed there, and soft tissue graft were also placed there. It took about 2 years job to finish this patient, to finish the treatment of this patient. Since 2004, 2005, from the work of Danny Boozer, we all know that the placement of the implant should be 1 millimeter palatal to the line that is joining the incisal edges of the adjacent natural teeth. So this is the position that everybody is familiar with it. Now the question is that with which angulation we have to place the implant in this position, with a buccal angulation or with an incisal angulation or with a cingulum angulation. To find the answer to this question, we have to go back to literature, and it's very obvious that you can find the answer, hopefully. Thankfully, there were so many good researches done on this thing. And you can see that if implants are placed with a cingulum angulation, the thickness of the soft tissue at the buccal surface would be around 3 millimeter, and there will be just 3.5% chances of crystal soft tissue loss. But if you place the implant with an incisal angulation, you will have around 2 millimeter of crystal bone, crystal soft tissue remain at the buccal surface, and 20% chances of crystal soft tissue loss. And if you are not very good and place the implant with a buccal inclination, then in 53% of the cases, you will have soft tissue loss at the buccal surface, and the thickness of the soft tissue would be around 1.7 millimeter. Anyhow, now we know the exact location, we know the angulation. The question is that what should be the contour of the restoration in the subgingival area to preserve the crestal bone and also to preserve the soft tissue. This is a case that we did around 25 years ago with a periodontist, a friend of mine who was graduated from UCLA. This gynecologist was coming for summer vacation, was visiting his family, and you can see that two central incisors were hopeless. and they should be extracted. By that time, I didn't have any temporary abutments, and the patient was not willing to receive any removable temporary restorations, any kind of fillipper. So, what I did, I asked my surgeon to extract the teeth, place two implants, and I cut the teeth 4 millimeter below the CEJ. I hollowed the tooth, and with the help of some flowable composite, I bonded a abutment inside the tooth. And these two teeth, I screwed them into the place, and you can see the screw access channel I filled with some cavet, and I was hoping that the patient will come back after 6 months or after a year, and I will replace these two artificial these two natural crowns on artificial implants with artificial crowns. But each year that the patient is visiting his family and also visiting me, he is refusing to replace them with artificial crowns and keeping them. So, at the first place, I thought to myself that this is the magic of temporary restoration that can keep the crystal bone and also the soft tissue level. So, I tried to place temporary restorations for all for all implants. And these two red arrows that you can see on the photo here, I'm pointing to the area of the problem. I was not consistent with the results that I was achieving with all temporization of the implants, because I made all these temporaries like this, very bulky at the cervical area, very convex at the cervical area. And in those cases that the thickness of the soft tissue was more than 3 millimeter or 3 millimeter, the result was good. But in the cases that the soft tissue thickness was less than 2 millimeter, then I would end up with very disastrous results sometimes. So I finally found that the problem is the contour of the restoration in that area, and this valuable paper published in 2010, 2009. You can see that they have concluded that the subgingival contour of all implant restoration should be concave in order to keep the crestal bone and also the soft tissue level. And in another paper by Stephen Cho at 2019, you can see that in order to keep this tiny spike of crestal bone, you have to make the subgingival contour completely concave. So these are very basics, and this is another example by Cho that he has used a metal abutment over here, and this metal abutment caused this loss of soft tissue. And when he replaced this metal abutment with some zirconia abutment, which is concave in the subgingival area, the soft tissue is back into the place. Now we know about the location, the angulation, and also the soft tissue contour in the subgingival area and the subcritical area. The other question is that how deep we have to place the implants in the aesthetic zone. We all know that we need at least 4 millimeter distance between the platform of the implants or the crestal bone and the soft tissue level. So this we call it the running space, and this is a very old case, 25 years old. Metal ceramic restoration, metal abutment, and this is a metal ceramic restoration on top of it. And because the restoration was placed enough 4 millimeter deep, we have enough running space to make the emergence profile and also the subgingival contour, which the lab technician made was again concave, and it kept the soft tissue contour of the patient for the patient. Let's get into some other cases. This young lady was 22 years old when she was referred to me. She had an accident when she was skiing and lost the 4 upper anterior teeth, and the surgeon placed 4 tissue level implants for this patient. This is the second time that these photos I took at the second time that I was visiting this patient. At the first time, when I saw this young lady, I asked the surgeon to explant the upper right central incisor because it was placed too far buccally. So this was a big disappointment to the patient. And then this is the lateral views of the patient, both from the right and left side, resting and also when smiling. You can see that the upper left central is still too much buccally. It's clear here that the upper left central incisor should be explanted as well. So again, I asked the surgeon to explant it, and the patient was really unhappy with this thing. The message of this series of slides is that you can limit the number of implants in the aesthetic zone to as less as possible. There's not this much need to place one implant for every two that is missing. Pontics are much more static than the implant restoration themselves. So I placed the temporary and two lateral incisor, and you can see that the aesthetic results on the pontic area is it's much more beautiful than placing two implants over there, and the challenges to make static in that area. And finally, this is the final result, zirconia bridge on top of those lateral incisors, and the lateral views of the patient, the frontal view. The lab technician was happy, the patient was happy, and I was happy as well. Anyway, but I'm going to tell you that zirconia is not the solution, is not the answer to all the challenges that we are facing in the anterior maxilla. Again, two lateral incisors were lost, and two implants were placed in those areas. Both canines were root canal treated at the upper right canine. There was an old casting post and core, and there was a veneer on the upper left canine. Okay. So I saw this case. It was around 13 or 2014. I had my first Omnicam, and I was not very confident that with the help of an Omnicam, I would be able to accurately scan this patient. So again, I made some polyvinyl siloxane impression, poured the plaster models, and you can see that I have placed two angled multi-unit abutments on top of the implants to correct the unparallelism between the implants, and also to correct the screw access hole opening from the buccal side and move it toward the palatal side. So if you look at the plaster model, you can see the final buccal surface of the restoration, the incisal edge, axial inclination of the natural teeth, and axial inclination of the implant itself. And with the help of a Duralay substructure, I was able to verify that my impression was correct, whether I will have a passive fit on the restoration or not. Another thing that you can realize on this model is that the final buccal surface of the implants will be placed too far buccally. And if you want to restore this patient with zirconia bridge, it would be really, really challenging, and the bridge will be very susceptible to fracture. So I asked the lab technician to to print a model, and with the help of that model, I fabricated the resin mock-up, and then this is the resin mock-up. The amount of lip support and tooth show was verified inside the patient mouth. The patient was not happy with the amount of tooth show, so you can see that I have added a little bit of Duralay at the incisal edge of the resin mock-up, and here is the final tooth show of the patient. When she was happy with the amount of tooth show, I asked the dental technician to turn it into a metal ceramic crown. This is the final restoration of the metal ceramic crown on top of the implant and the natural teeth. So the message of this part is that zirconia is a very good alternative to metal ceramic, but you cannot use zirconia in all cases. Another example, this gentleman in late 40s, he was treated by another colleague on anterior maxillary implants with zirconia bridge, and he was not happy with the look of the zirconia bridge. There is a fracture, a crack on the zirconia, and also the adaptation of the zirconia to the. I mean, the lab work is really poor for this case. So what I did, I took out the zirconia bridge, scanned the case with an intraoral scanner, and fabricated printed a model. And with the help of a model, I printed the temporary, and then finally turned the temporary into a final restoration. Again, a metal ceramic crown, not metal ceramic bridge, not a zirconia bridge, because I wanted to make a little bit of individuality for this patient, and I cannot reduce the size of interproximal joints with zirconia this much. So, as a final conclusion to this phase, I have to tell you, even today, metal ceramics as implant supported restorations are considered to be standard. And they are well documented, provide excellent long-term clinical outcomes, and have high mechanical stability and acceptable aesthetics. But I'm sure that zirconia is a very good alternative to these material, and in the near future, there's a possibility that can overcome the challenges that we are facing today with zirconia. Zirconia is a very good material in some cases, like in this case. Mm, Tissue level implant was placed for this patient, central incisor, resin mock-up on top of the metal abutment, and finally this turned into a zirconia crown. The patient did not want to touch her natural teeth with veneers or anything, so she was willing to just receive a crown on top of this implant, and the result is quite acceptable for the patient. But zirconia crowns are not very good if the thickness of the soft tissue is less than 3 millimeter. Then there's this metal grayish metal color show off in the cervical area, and even though the crowns are very good looking, but the grayish metal show off is not good for the patient, and she's not happy with the result. So, in order to overcome this grayish metal show off in the cervical area, one of the first attempts that we made in prosthodontics was to cover the metal abutment with some kind of opaque material. Metal abutments are very good because you can reduce the axial thickness of this metal abutments to 0.7 millimeter, and they still will withstand the forces of mastication, and they will not fracture. So metal abutments are good from this point of view. But aesthetically, the grayish color is a challenge to aesthetic dentistry, so we covered them with this opaque material. And of course, when you cover them with this opaque material, the final crown restoration will be a little bit opaque, and therefore it's not very acceptable from the patient point of view. Um, as I told you, if the thickness of the soft tissue is good, you can use metal abutments. If the thickness of the soft tissue is around 3 millimeter, then you can use metal abutments with shoulder finishing line or with chamfer finishing lines. These are good abutments with shoulder or chamfer finishing lines. Like in this case, upper right central incisor, an implant was placed, and HO lithium disilicate was injected on top of it, and this is the final crown for the patient. Still, the shade is a little bit opaque, but acceptable. But what if the thickness of the soft tissue is less than 3 millimeter, it's around 1.5 millimeter? Then, instead of using a metal abutment with the shoulder or with the chamfer, finishing line is much better if you can use a shoulderless abutment. These shoulderless abutments, they do not have any finishing line on the buccal surface or on the proximal surfaces. They just have a very small step at the palatal side, and this will help the crown to sit on them perfectly. And another advantage of using shoulderless abutments where the thickness of the soft tissue is less than 3 millimeter is that the soft tissue will rest upon the surface of the metal abutment itself. It's somehow like a BOPT preparation on natural teeth. And of course, another solution to the challenge of grayish discoloration in the anterior maxilla is using of white abutments, zirconia abutments. Zirconia abutments are very useful if the thickness of the soft tissue is less than 3 millimeter, and you will not face the challenge of grayish metal show off in the maxillary area. This is the final result with the zirconia crown on top of a zirconia abutment. But the problem with zirconia abutment is if they reduce the axial thickness of this abutments to less than 0.9 millimeter, there's always the risk that you can fracture the abutment itself. So, uh, what I'm telling you is that zirconia is not the material of choice for all cases in anterior maxilla. It should be planned very carefully if you want to place zirconia crowns on top of it. This patient, she did not visit me at the first place. She went to a surgeon, and this is the photograph that the surgeon took during the surgery. When he opened the flap, he saw that there's a buccal depression at the site of implantation. The lady is in her late 30s, a very beautiful long gynecologist, and you can see that the width of the bone is around 3.5 to 4 millimeter. If I was visiting this patient at the first, if I saw the patient before she was going to the surgery, I was advised the surgeon to do a staged implantation. I mean, place some bone graft, wait, and then place implant in a more palatal position, because the aesthetic is a real concern for this patient. But the surgeon placed the implants, and you can see that the threads at the buccal side is exposed. Bone graft placed, connective tissue graft, and the surgeon was very happy with the result of what he did. After 6 months, he took this photo. There's that metal discoloration because of the remaining metal object in this site, and he referred this patient to another prosthodontist. Another colleague of mine restored it with the zirconia crown. Both the surgeon and the prosthodontist, both of them were very happy. They took the photos, they took the panel, and they were quite satisfied with the result. But the patient was not satisfied. She was complaining that during every meeting or during every party that her friends are taking photos of her, this zirconia single crown is shining like what you can see in these photos. And these are the only photos that this young lady gave me and gave me the permission to use it in this presentation. I didn't have the chance to take any photos from her face, but she was complaining of it and was insisting to change this crown. What's the solution? To take out this implant? No. You can see that beside the shade, there's a problem of contour of the restoration as well. And also there was this metal stock abutment for this implant. One solution was to explant it, bone graft that area, place this implant. The patient will suffer a lot if I choose this kind of treatment planning. So I tried to solve it with some kind of prosthodontic work and with the help of a very good dental technician. This is the over contouring of the restoration. You could see it's obvious from both lateral views. And I used a tie-based abutment and asked the dental technician to make a hybrid lithium disilicate crown on core on top of that tie-based abutment, and a lithium disilicate veneer on top of that core. I cemented the tie-base and the core together extraorally. This is the position of the core cemented to the tie base intraorally. You can see the screw access hole right underneath the incisal edge of the implant because the implant was placed too far buccally, and this is the final veneer cemented intraorally for the patient. And with the help of this technique, we were able to solve the over contouring of the restoration as well. So both the shade problems for this patient was solved. But if the surgery was done good at the first place, there was no need for um, all these too much work for this patient. And another message, zirconia has a very different refractive and refractive index. So when you put it among the natural dentition, it will cause problems when the patient is smiling in different light conditions. These days, everybody is buying an intraoral scanner, and they are telling that we are all digital, and all the workflows that they are using in their offices is digital. And to my idea, some cases you are still like in full mouth reconstructions. Either you have to full mouth reconstruction with implants. Either you have to go to photogrammetry or um, uh, use very special techniques to overcome the problems of intraoral scanner, or you have to switch to silicone impressions. Anyway, there are some reasons that we need full digital workflow. For example, when we're doing immediate loading, or when we are doing non-functional immediate loading, or we are doing monolithic restorations on model-free workflows in laboratories. So, what are the steps that we are carrying in the full digital workflow? These are the steps that we are carrying in a full digital workflow. We will take an intraoral scan, a CBCT, we will combine the STL and DICOM files with the help of a software, we will design the surgical guide, we will print the surgical guide, and place the implant under guided surgery, and also immediately load the implants. Like in this case, taking the STL file from an intraoral scanner, the DICOM file from a CBCT, combining them together, designing the surgical guide, printing it. In the old times, I believe that milling the surgical guide makes a more accurate surgical guide comparing to printers. But since 2020, I realized that the accuracy of printed surgical guides is similar to the milled surgical guides. So actually, there's no difference between them. And there's this beautiful paper published in JPD, I guess it was September 2024, that was comparing three different softwares, the accuracy of three different softwares in designing a surgical guide, comparing co-diagnostics, tree shape, and I guess a real guide, and they found that there was no difference in the accuracy of the gut between the accuracy of the guides fabricated with these softwares altogether. Anyhow, upper left lateral incisor, hopeless, vertical root fracture. The guide was designed and fabricated, printed. The tooth was extracted with the help of a peritom. This is the surgical guide placed, the implant placed with the help of a surgical guide, bone graft, connective tissue graft, and you can see that the insertion torque is more than 35 Newton per centimeter, and the NHC number is around 57, which are very good indicators that this implant can be immediately loaded. Then I made some intraoral scanning. You can see that the implant is placed very deep. Sorry. The implant is placed very deep. The amount of scan body on top of the soft tissue is very low. Here it is. And then, with the help of this scanning, I was able to fabricate a temporary restoration, printed it for the patient. All subgingival contours are concave, and the screw access hole is located right under the incisal edge of the temporary restoration. This is in place, the temporary restoration on top of a tie-base abutment screwed into the place. And after the 2 months, we have to deliver the final crown for the patient. I realized that if I was going to use the same tie-base abutment, I will end up with the same result with the screw access hole underneath the incisal edge. So I use the premal abutment. This is the premal abutment, and a zirconia crown on top of it, and this is the final result for the patient. Not all cases of immediate implantation with guided surgery are successful and can be used for immediate loading. These days, patients are even asking for immediate loading of single molars, which I don't know why they are asking so much, but this is demand in the market, and immediate loading is getting very popular. So this patient was asking for an immediate loading for this hopeless upper left second premolar. I told the patient that because of the extent of the bone loss at the palatal side, there's always the risk that we cannot immediately load it. But the patient was insisting, so it was extracted. The implant was placed. You can see the insertion torque is 20 Newton per centimeter, and the NHC number is 48. So these are indicators that we are not going to immediately load this implant. I tried to fabricate a half crown. I wanted to cut this crown on ExoCAD and make a half crown, but I realized that even 1 millimeter GH tie base, there's the risk that I can fracture the. So, uh, okay. So I asked my dental technician to um, use a Premal abutment. This is the Premal abutment, and I turned it into a customized healing abutment. This is the customized healing abutment in place, and after 2 months, you can see that I replaced the customized healing abutment with the zirconia permanent crown for the patient. But this is very costly because we have to use a Premal abutment these days. Instead of using a Premal abutment, I use PEEK material to fabricate customized healing abutments, and with the help of these seating jigs, I place them for the patient. Another patient, a young lady, upper left central incisor was hopeless because of vertical fracture due to casting post and core, previously casting post and core for this patient. Patient smiling, you can see that the gummy smile, unleveling of the gingival contour at the left and right side, canting of the maxilla, but we're not going to solve all these problems during the time of implant surgery because the emergency for this patient was not to remain edentulous in the upper left central incisor. So the message of this part is that if you want to do immediate implantation in fresh sockets, sometimes it's much more better to do freehand surgery instead of guided surgery, and you can get more reliable results because the primary stability will be much more higher when you're using freehand surgery, and you will be able to restore it with temporary restorations. In this case, you can see that there's a diastema between two central incisors before extraction, and now the tooth was extracted, the implant placed. During surgery, the artificial crown of the patient did not fracture. It was extracted unharmed and untouched. So I used a little bit of composite on top of a tie-base abutment to fabricate a reverse abutment for this patient and delivered the same old crown to the patient. And here you can see that before and after. The only difference between the before and after is that the diastema between two central incisors has been closed, and the diastema is now between the central and the lateral incisor. It shows that the implants was so precisely placed and the primary stability was so good that the implant is not too far buccally or too far palatally. It's just placed a little bit toward the mesial side, and this is without the help of a surgical guide. So let's move to another case. In this case, when I saw this patient for the first time, she was 22 years old, and she was treated by an orthodontist, and also a maxillofacial surgeon has placed 3 implants for this patient. I asked the orthodontist at least close the diastema between the centrals, and then he debanded the patient. You can see that there's unleveling of the gingiva between the right and left side, and there's uneven distribution of space between the right and left side of the patient. 2 implants at the left side, 1 implant at the right side. It was 2015 or 2014. I didn't have any DSD software at that time, so I used the ExoCAD Smile Design. I know it's not very powerful these days, but that was the only tool I had those days. And with the help of the digital smile design of ExoCAD, I found that I have to place restoration on the natural teeth as well in order to make some space management. So I prepared the natural teeth for porcelain laminate veneers, and I took the impression with polyvinyl siloxane. You can see that I placed tie bases on top of the implants, and the natural teeth are prepared for Veneers. The challenge here is that if I fabricate zirconia crowns on top of the tie-based abutments and lithium disilicate veneers on top of the natural teeth, then the refractive and reflective indexes of both materials are different. And there will be a challenge in shade matching and different light sources. So I decided to ask the dental technician to fabricate some hybrid abutment on top of the tie bases. These are hybrid lithium disilicate abutments on top of the tie bases. And again, seven lithium disilicate veneers on top of all natural teeth and implant itself. This is the final restoration. And I guess this is 9 or 10 years after the surgery, after the placement of the restoration. Sorry, this is before and after of the patient, and you can see that the patient has lost her lower right first molar, and one implant has been placed over there, still not restored. But the condition of the implants in the in the anterior maxilla is quite satisfactory, and the aesthetic result is good as well. Digital tools are very, very important in helping us to define the final outcome, final aesthetic outcome of our treatments. If you look at the photo at the left side, you can make sure that the implants are positioned properly. Two lateral incisor replaced by implants. The width of the bone is enough. They look good. If you look at the right slide, you can see that there's a little bit of unleveling at the gingival area between the left and right side, which doesn't look very, very serious. But if you take a photograph of the patient smiling, and if you do a face scan, then you can realize that there's a big problem here between the left and right side of this patient. And if you just try to fabricate and just scan it and send it to the lab, the final result would not be aesthetically acceptable. So, with the help of this face scan, I designed a smile design with the software itself, and I exported it to the exocad as well, before and after. And this is the final restoration with the help of this face scan fabricated for the sorry. Another very challenging case, a young lady in her 40s. She was under orthodontic treatment for about 9 years, and you can see gummy smile, disrupted curve of SPE at the right and left side. And also another problem is that upper right central incisor has been fractured and has to be extracted. So you can see the lateral tongue thrust for this patient. She was not willing to go through any orthodontic or any maxillofacial treatment. She just wanted to fix it with restorative treatment. I know this is not the ideal treatment, but the patient, I cannot convince the patient to go to any orthodontic treatment after the experience she had for 9 years. Another challenge with this patient was that she was suffering from a very deep bite. You can see it, a very deep bite, a fractured upper right central incisor. So I made a surgical guide, asked the surgeon to extract it, placed it exactly at the cingulum area with the cingulum angulation. And with the help of an angle solution tie base, I was able to restore this restoration. And what is the angle solution tie base? These are, let me share it here. Okay. This is the angle solution tie base. Here you can see it. And the buccal wall is completely untouched. The palatal wall is a little bit shorter. And with this angle solution tie basis, you can move the screw axis channel about 20 to 30 degrees toward the palatal side. Of course, you have to use a special screwdriver. And this is a very good solution in those cases that the screw axis hole appears at the buccal or at the incisal edge. And this is the final result. The patient was happy again. The problem with angle solution tie bases and zirconia restoration is about minimum thickness at the axial wall. Upper left lateral and canines were restored by two tie bases and zirconia core. Here it is. They look pretty good. If you look at them from the incisal edge, the lateral looks good, but the canine, I guess that the minimum thickness at the screw axis hole area is not enough. So I tried to measure it with a gauge, and to my surprise, it's zero point 0.4 millimeter. And we know that the um, minimum thickness at the axial wall should be around 700 microns. So it makes it 400 microns, make it very susceptible to fracture. And this is if the dental technician covers this area with some kind of porcelain, it would be impossible to realize that the thickness is not enough. So in this case, what I did, I asked the dental technician to change this angle solution tie base to a Primel abutment and fabricated a cemented crown on top of it. The other solution is to use angle tie bases. They are not available for all brands yet. Some brands they have it, some brands they don't have it, but they're very good solutions and very good things to use. Niels Bohr has a very good statement. He stated that an expert is a person who has made all the mistakes that can be made in a very narrow field, and that's what makes us prosthodontists. This is my first zirconia crown 25 years ago on a natural tooth. Upper right central incisor restored with a casting post and core and a zirconia crown on top of it. You can see not my ceramic work, neither my photography was not very good, but I was very excited because this was the first zirconia crown I had for this patient, and I took so many photographs, and this crown served the patient for about 19 years, and after 19 years, it failed. Vertical root fracture. It was replaced by an implant. So I scanned it, used a tie base abutment, a hybrid zirconia core, and a zirconia crown on top of it. This is the result. I was very happy with the zirconia crown. I took photographs, put it on Instagram. The patient was happy just up to 6 months. After 6 months, she walked into the office and the hybrid zirconia crown was fractured from the cervical area. So I have to change the tie base to a Primel titanium abutment and replace the crown with a new zirconia crown on top of it. So I'm telling you that tie base is not an answer, again, to all our challenges in the oral cavity. And the final case is this young lady, a medical doctor. She was mountain biking and she had an accident, lost her upper left central and lateral incisor, replaced by two implants, restored the whole anterior segments with zirconia crowns and also with veneers. The patient and me both were happy for 2 years. After 2 years, the patient was walking into the office and she told me that she had a fistula on top of the left implant. And I thought that maybe I'm facing a kind of screw loosening. So I raised the lip and I saw that the fistula is not on top of the implant, but it's on top of the left canine. And this is the result, photo X-ray of the canine, and you can see that I was facing invasive cervical resorptions after 2 years of the trauma. I mean, more than 2 years, after 4 years of the trauma itself, after 2 years of restorations in place. And this is a class 4 invasive cervical resorptions, no other solution except for extraction and placement an implant with the help of a surgical guide. So as a prosthodontist, when we are happy, when we're sad, we're mad, we're amused, we're loved, we're confused, disgusted, shocked, angry, we always look the same. The only time that we're smiling is when the treatment is finished and the patient walks out of the office happily and will never come back. Thank you very much for your attention, and I hope that this presentation will help to solve some of your problems in your daily practice in your offices. I would love to have your comments or questions if there is any. Thank you very much and have a very good time. Bye.